Hello guys, welcome to today's webinar. Today we'll be speaking about the basic information about injectable technique in anterior and posterior dentition. Whoever is joining us live from the Facebook or Instagram, you can also join demio.com platform on the link that I have already posted. You will have just better quality of the image, but you can also stream from the Instagram or from the Facebook. Now we will wait 2 more minutes while everybody logged in. During the webinar, you're very welcome to ask any questions. After we finish, we'll have like 30 to 45 minutes webinar. I will answer the questions first from demio.com, and later on I will check also the questions on the Facebook and in the Facebook group, and also on the Instagram itself. If some questions will not be answered, I am inviting you to join our Facebook group. You can see it here, Injectable Technique, Flow Injection Molding Technique, and ask in the group, in the post, any questions that arise. And now, hope everybody who planned to join are alive with us today. I'm sending regard in front of Injectable Technique online platform from all of our staff who is doing a great job in our online education. I'm always starting all of my courses, all of my lectures or webinars with this slide with the word simplicity, because this is my main guidance in dentistry in general, but also for the injectable technique. And I think we should all follow this thought, how to get good aesthetical and functional result in efficient and simple way, trying to avoid any kind of complex procedures, and of course to avoid any kind of complication. Oops, wrong slide. I am like this girl playing in the sand, fascinated by all different branches of dentistry, but my manual skills are not on the highest level. But like this girl, somebody taught her how to fill the bucket with the wet sand to reproduce this great morphology. And something similar I will be showing you today, how to get from this clinical situation into this one in very predictable and precise way. What do I mean by predictable? All of us that are streaming live or who is watching the recording, all of us will get the same result if we had the same planning, because of the predictability of injectable technique. My name is David Gestakovski. I'm coming from Croatia, from Zagreb, where I'm working, where I've studied, and where I'm living. I'm working in a small private practice together with my parents. I'm sending regards to all of our staff, our whole team, both in the lab and in the clinic. And I'm always proudly mentioning my dear grandma and grandfather who started our family dental tradition. Now, guys, I'm inviting you all to join this Facebook group, Injectable Technique, Flow Injection Molding Technique. I picked up all the synonyms for this concept. We already have 1,500 members, and I'm encouraging you to post your cases, to ask any questions, post any problems that you can have. You will find also in the webinar my contact, but I prefer, because I'm getting a lot of messages nowadays, if you share your questions or your results or any doubts, anything in this Facebook group, so everybody can learn from each other. This is the idea of our community to grow. At the moment, we are streaming live also in this Facebook group, but as I mentioned on Demio, maybe you will have better quality of the image and the video and sound. So let's see how we can get from the upper to the bottom result very efficiently. When we speak about the injectable technique, there are different synonyms for this, as I would prefer to call it concept. It is resin composite injectable technique, flow injection technique, injection molding technique, the synonyms for the same thing, where we are basically copying our plan with the transparent silicone index that you can see in the photo directly in the patient's mouth. So here we have the initial situation of the patient, which was later on waxed up. The wax up is copied with transparent silicone, which is used later on for the delivery of direct restoration directly in the patient's mouth. So this is some kind of indirect direct technique where everything is planned in the articulator in the lab by technician following all aesthetical functional parameters, and later on delivered directly in the patient's mouth, which gives us opportunity to stay less or minimally or non-invasive. Okay, we are etching and bonding, which is not non-invasiveness, but still there are some situations where we can inject teeth from different aspects, for example, for modified 360 veneers and so on, without tooth preparation, because we don't have path of the insertions like we have for the ceramic veneers. Don't get me wrong, I'm also doing ceramic veneers, but sometimes patients really like this concept. My story with injectable technique started in 2017 when I did one of my first cases, which was later on published in Quintessence International. Just to give you an idea about the simplicity of the technique, I made this case when I was fifth-year student, which means tomorrow when you started, and it was later on published in Quintessence International, which means later on when you start practicing this technique, you will for sure get even better results. Whoever have doubts about the longevity of such veneers, here you have 5-year follow-up of this same case, which is today at this moment more than 6-year-old, but I don't have yet the follow-up photos because the patient didn't come this year for the follow-up. I'm waiting for him in the next month. By the way, these publications and some more publications of mine you can find in this link on the bottom of the slide here on www.injectabletechnique.hr in free education sector on our online platform. In the publication sector, you can find this article and you can download it for free in PDF format. Also, you can find there some tutorial videos about production of transparent silicone and so on, which we will not cover today. Now, let's speak about the protocol of injectable technique, and later on I will explain some more about case selection and some preparation for the treatment. But let's start with the most important and the most interesting part. So first, I would advise you to check seating of transparent silicone, because maybe something went wrong in the impression phase, in the production of transparent silicone, and we don't have stability. So first we need to have stability, and then we can start with etching, bonding, and so on. This will be our model today, single lateral, which was well documented with the close-up photos. That's why I'm showing you it, but you can also do it in multiple teeth as well. We're starting with the etching of the full dental surface that we plan to inject composite on top of it. Here you have surfactant layer of unprepared enamel, where you have aprismatic enamel, and you want to open those prisms so you can or sandblast or roughen the surface with some rough disc, or prolong the etching time to improve the adhesion of your future composite veneer. After we rinse and dry, then we go for the for the perfect isolation. For the anteriors, I'm not using rubber dam. For the distal teeth, I'm using rubber dams. Distal teeth, I will show you later on. First, we're starting with the anteriors, which are, from the aesthetical point of view, more challenging, but from the technical point of view, I would say it's easier to work on the anteriors than on the distal teeth. So for your first case, I would advise you to stay with the veneers and later on move on the distal direct table teeth. When we speak about the isolation, I like to lay down my patient so he is or she is lying down, and also I will go down the throat. I use some lip retractor and isolate the adjacent teeth with the Teflon tape. In some cases, I place the dental cord in initial part of dental sulcus to prevent fluctuation of the subcolor liquid in the field of work, and also to prevent fluctuation of flowable composite in deeper layers of sulcular area, so it's later on easy for me to clean up the margins. Then we start with the adhesion. I like to use universal adhesives, which after you air spray, they stay in super thin layer like G Premium Bond, like 5 microns, something like that, which is great for our non-prep restoration. Then we go for the injection phase. During this phase, please check if your silicone is well stabilized. I stabilize it from both vestibular and incisor angle, and inject while I see the excess of the composite on the margins of my transparent silicone. As you can see, I'm cutting my transparent silicone following gingival margin, so it's easier for me to remove this excess while it is in this light polymerized state after a few seconds of polymerization. Then we go for the full polymerization. I double time from the vestibular and incisal and palatal if needed, if we're doing palatal veneers as well. And this is after removal of transparent silicone. Now, you can see those layers of the printer here in this case, because this is old case, like 4 years or something. Nowadays, I ask my technician to polish the model, or we print it on more fine precision. When we speak about the removal of the composite material, first we start with the metal stripe like this and help myself with the scalpel blade number 12, which is great for removal of the excess in this part. Here I don't like to use scaler, because scaler goes underneath the composite, the attached composite, and causes staining. Okay, so for me, scalpel blade is much more useful. I polish the margins with such diamond polishing burr on low RPM. You can help yourself with the Heidelman spatula or specifically designed instrument Zechria. I think we don't have it here today in the presentation, but it retracts the gums and protects it while polishing the margins. And then if you have this polishing cones from the Intensive or Eve, Cabo, and so on, you can use it for polishing of the papillar area. Super useful instrument because it doesn't have cutting edge. You can use whichever polishing diamond rubber to smooth out if you have those layers, or if not, you go straight to the polishing till the high gloss. I like to use Epitex thin stripes, Epitex, the blue one and the green one, to polish interproximal surfaces. And when you polish, always make this S formation. With this S formation, in one orientation, if I am polishing lateral on this slide, you will be polishing more palatal, and here you will be polishing more the vestibular surface of your veneer. For the final gloss, I like to use some flexible spirals on low RPM, okay, without water cooling for better friction. And for the final touch, I like to use the polisher paste in combination with cotton buffer like this one. And this is all that you need to achieve nice gloss of your restoration. This is the day after, and few days after, I think, yes, here we have the photo. And trust me, this was single shade restoration, but with proper shade selection, proper morphology and micromorphology, you can integrate your restoration in the full dental arch like we did in this case. Here we have the before and after. This is old case, which was later on published in International Journal of Aesthetic Dentistry. You can also find this case online and read it with the full procedure, which I actually showed you today. And here you can see how nicely we can integrate and copy natural morphology with the injectable technique, because this was done in the lab. The whole planning and whole design was done in the lab, not by myself directly in the patient mouth. Because if I was doing here the freehand bonding, most probably I would not be able to achieve this great morphology. So to sum up the protocol, we have etching, isolation, bonding, application of the composite, light curing, finishing, and polishing. Like for any other composite restoration, it's just that we are applying the material that we are using, usually flowable composite, on a little bit different way while injecting in the transparent silicone. Okay, so just the idea is think out of the box. So I prefer to call this the concept, okay, because we are copying our wax up. And you can find this publication on the same link on www.injectabletechnique.hr, again in the publication sector. You can download it for free in the PDF, and there you can also find my another case report which was published in GC magazine. Now, usually I'm holding online courses which last for 8 hours. Today I try to summarize the most crucial part for your information about the injectable technique. And by the way, whoever later on want to register, in the next 24 hours we activated 10% discount code May 22nd. If you put this code, you can get a discount. Please be more than welcome to type down the questions. I will answer them once we are done. So you can find the online masterclass about the veneers in Spanish, in Italian, Croatian, and English, both recorded and live. Live is of course in English. And now I will go through the things that we are usually mentioning, that we are explaining in details in our 8-hour masterclass with most important stuff. In the introductional part, we always check what is written in the literature. And maybe some of you are a little bit skeptical about usage of flowable composite in for the use for the composite veneers. This is totally fine, because back in the days, not all flowable composite, actually back in the days, non-flowable composites were good from the mechanical or aesthetical point of view. But the conclusion of this systematic review was that flowable composite exhibit variable compositions and consequently variable mechanical physical properties. The clinician must be aware of this aspect to make a proper material selection based on specific properties and indication of each material relevant to a particular clinical situation. Which means, yes, there are some flowables which are meant only for fitting the fissures and so on, but maybe there are some, and I assure you that this new generation of so-called injectable composite have amazing mechanical and aesthetical properties. We are describing this in the masterclass more detail, but for you now, you need to trust me without showing you 100 of different scientific papers. Then about the materials, I like to use the most clear material, the one on the left side of the screen, the ExaClear from GC, because it's super clear. And if something happens inside, if you get some bubble and so on, you will be able to see it and to resolve the problem before light curing. Okay. From the composite point of view, I like to use Genial Universal Injectable because of the gloss of restoration that we can achieve. Here is one single shaded restoration only after final polishing. And I'm lecturing or teaching a lot of hands-on courses, and my favorite part of each hands-on course is to check the face of the participants after they do super fine polishing, because everybody is stunned how nicely this composite can be polished. And we're working on the models without saliva, without water, and it's gloss like crazy, like you can see in this photo. Okay, so for this reason, I enjoy working with Genial Universal Injectable because of the amazing gloss that can be achieved, but also the gloss that will stay after some time. When we speak about case selection, here you need to be a little bit critical, okay? This is not a technique that you can do in every patient, okay? I'm always trying to do everything purely additive and minimally invasive. I do everything without prep. All the cases that you will see in my online masterclass or today on the webinar, non-prep, okay? I don't like to touch the tooth, which means we need to have space, okay, to add some composites. So some diastema cases or peg laterals, rare cases, if the function allows us, sometimes we need to go for full mouth rehab, for raising of the bite, and so on. Some misalignment of the teeth. All those cases we are explaining in detail, each case containing more than 100 photos and videos in the extended version of the masterclass. Retrougional position of the teeth, perfectly indicated, because we just need to add some space. Multiple diastemas, of course, but in some cases we need to go for the pre-prosthetic ortho. Here we have before, after ortho, and final result. Okay, so sometimes you need to go for the pre-prosthetic or ortho, or if the teeth are already too big or too protruded, it's not indicated. Don't try to push the limits of the indications, otherwise the result won't look good, the patients won't be satisfied, and you will have problems. So try to stay with the limit of the indications. When we speak about the planning, I'm always starting with the intraoral and extraoral photography, doing some DSD, face analysis, and so on. Taking the impression, you can take the scanner or you can do the analog way. The most important part is that you follow the orientation of the horizontal, no matter if it's with overlapping of the photos or with the face bow, but always think about the function, because without the function you cannot achieve long-lasting aesthetics. So I'm always mounting in the articulator, and my technician later on place it in digital articulator in referential position. So we have everything planned with all the movements of the mandible. My technicians design the wax up. About the wax up, you can go for the analog or for digital. In the analog, you will have more ability of the micromorphology. With the digital, you will have some other advantages which will speed up your procedure. But the best thing is, here you have the wax up, then you try the mock-up. And in the mock-up, you check everything: function, phonics, aesthetics, the all important stuff. And when you do the veneers, they will look the same. This is the most. Today I had 2 consultations for this kind of the restoration, and the patients like the idea of seeing themselves before going for the final treatment. With the freehand bonding, it's not possible, okay? But with injectable technique, we can show them exactly how they will look, later on achieve the same result. Then, after our wax up is ready, no matter if it's analog or digital, we go for the production of transparent silicone, which is basically impression of this wax up. You need to pay attention on the thickness, because the thicker it is, the more stable it will be. I like to cut my silicone index following gingival margin, like you can see on this photo, and then you make the holes for the tip of flowable composite through which you are going to inject later on. About the intraoral procedure, I already showed you the photos, so hopefully you got this part in detail regarding the application of the composite and finishing and polishing. And about timing and pricing, I can tell you that I charge double injectable technique case than freehand bonding, because of all timing which is dedicated to the case itself. So this is in the first webinar that we are speaking about. It lasts for around 3.5 hours, and in the second webinar, which is around 4.5 hours, we are showing different modifications on more than 15 different clinical situations. One of the modifications that was explained in Quintessence International publication is the usage of the space holders. Whoever is working with the analog models, to prevent access of the flowable composite, this is the thing that will help you. In the case serial, we are showing different modifications, how to achieve polychromatic appearance, but also how to make polychromatic veneers, because you can combine different shades. Here is 20 months follow-up of polychromatic veneers, where the incisal part was done with a transparent shade, as you can see. What in case of the fractures? What do you do usually? You layer down different shades, and with injectable technique, you can also layer down different shades, okay, and still achieve this morphology. Have in mind, here it's not my result; it's the result of my technician. Okay. Can we do with the interproximal cavities, interproximal caries, or old fillings? Yes, of course. But first, we need somehow to block the black from the background and later on inject on top of it and get this result. The uppers are also composite veneers, the lowers are also composite veneers, but you can see quite difference because of the design, approach, and polychromatic protocol. We speak about the control of the function because you need to be aware that no matter which material you put in the patient's mouth, if you have functional problem, it's going to chip. So I am explaining over there in details now for your information. Have in mind that every case I finish, I advise patient to make them hard acrylic Michelin splint for long stability of the result. I am having chipping very, very rarely. I can count them on one hand, but most of the time they were because of some technical issue. Okay, if the function is properly designed, even the bruxers who don't wear splints, I don't have chipping. I have just slightly more incisal wear off after time. How to save time? You can do different modifications. My favorite is double model technique, where my technician print two models, one with every second tooth wax up, another with all teeth wax up. Based on this, we make two transparent silicone index for first and for second injection phase, and then we have super easy job with not much of the excess of the composite on adjacent teeth, and it speeds up your procedure for 30 to 40%. In those 15 cases, we combine or we compare analog and digital approach. And now I would like to mention the most common mistakes, because in Croatia we have saying English people learns on Oxford, Croatian people learns on their own mistakes. I did all of them and I want to share them with you. Some of them are air trapping that can happen, but if you can see it, you can prevent it, you can remove it. Uncontrolled access of the material can be nightmare, so have in mind to have everything perfectly isolated and prepared in a proper way so you don't have big access of the composite. Wrinkly Teflon can cause some problem, and of course bleeding, which means we need to work on healthy gums, healthy patients without gingivitis. Okay. These are some cases that we are showing in detail in the master class, like those 6 veneers. And these are, for example, single shaded veneers. Sometimes we are combining the shades, but in 85% of the cases, you'll be fine with only one shade in the achieving nice aesthetic result. And here you can see all these details are basically captured from the model, from the wax up, and later on delivered directly in the patient's mouth. Before and after, you already saw this case in the introduction part. Check how much space do we have for the prolongation of the lateral. Not much, but with modified 360 veneers, we can resolve this problem. And very often I'm including canines in the therapy for this reason, to prevent chipping of the laterals. How thick are my veneers? The thinner, the better. Okay, try to stay with 0.2, 0.3 millimeters. Don't go this crazy thin, but some cases were done in this crazy thickness because I just want to reshape the tooth, not to make it bulky. Okay. And can we treat dental wear? Yes, of course. Sometimes we're treating one jaw, sometimes we're treating few teeth, sometimes we're doing full mouth rehab. Okay, so what about the wear? We can treat also distal teeth, like in this case. This is another story in the full mouth rehab, where sometimes we're restoring one jaw, sometimes we're restoring both, or restoring the palatal surfaces. Oftenly, people with some wear come for the veneers, and what you actually need to do is palatal veneers because they grind their teeth on the palatal surfaces. We're also running the functional program. It is scheduled on 10th of June live, but you can also get the access to the pre-recorded version today. It lasts for 6 hours, and the same coupon code, May 22nd, if you put on this in our online platform on the link, you can see on the top of the screen, you will have 10% discount. discount, the coupon code will be available for the next 24 hours. So tomorrow till the midnight by my local time. It is Central European summertime, something like that. Now, let me show you short protocol of the injectable technique in this in the distal teeth. Here, I like to isolate everything with the rubber dam, because you can isolate central incisor, but to isolate lower second molar, so. Okay, so I like to place the rubber dam on oral segment or the whole jaw, depending how many teeth I am treating, how many time do I have, and so on. Covering every second tooth with the Teflon, the same way, etching the thing, the place where I will be placing the transparent, not transparent, the flowable composite, bonding, everything that you do for your everyday restoration, as I would say, light curing, and then going for the injection phase. Under the pressure, if the silicone is well stabilized, you will copy your technician's modulation. First on one tooth, then on the another tooth. Here we did the direct composite tabletop. We raised the occlusal table and changed the later on vertical dimension in this patient case. First for one tooth, then for the other tooth, and then for the all other teeth which are planned to be included in the therapy. And even though if you follow specific rules of the design, you can get this nice shape of your restoration without big excess, without big problems, and so on. But have in mind, not every single case is indicated for this. Don't try to push the limit of the limit and indications of the technique. If the case is indicated, you can achieve very nice, long-lasting, and stable result. Here we have before and after this occlusal tabletops. This is after the polishing, or actually this is pre-polished version, where I check the bite. You can see maybe some contacts which should not be there, because we are always trying to get some B contacts. But about the contact points and the finishing of the occlusion, you can find out in our functional program, which goes much more in details. Now, this functional program is also well, well categorized, following different parts. And today I will try to show some most important steps. And here is the list is long that we are covering in the extended version, and here to give you the idea what you need to pay attention to. When we speak about dental wear, there are different potential cause: erosion, attrition, abrasion, abstraction, and so on. And it's rarely that they come isolated. Most of the time, it's the combination of already mentioned conditions. Have in mind that almost 1/3 of young population, okay, healthy young adolescents and young people, already have significant amount of the wear. So this is a raising problem, okay, that you will see often in the in your clinic, in the population. And when the case comes, you need to have all different potential treatment options. I'm not saying that this is better than ceramic. Ceramic is the gold standard, but sometimes patients cannot afford to do 32 restoration. And here we have some alternative. In the functional program, we discuss different treatment options. As I said, ceramic is also great, of course, and showing different scientific background. There we are discussing with more than 30 different scientific paper. I put this one from 3-step technique, where they had the 6-year survival rate of direct composite, where they raised the bite of 97.3%. So it's not so bad as somebody would say. And in the literature, you cannot, in the systematic reviews, they found no evidence that one material is better than the other. And the composite is not wearing so fast as maybe some of us would assume. which I found on the PubMed, even though I was also skeptical. And when I started 6 years ago with injectable technique, I also started only with the anteriors. Later on, I started with the distal teeth because I realized the materials have upgraded, okay? And with the proper materials and functional plan, we can achieve nice results. So I already spoke about the materials, Exoclear, Genial Universal Injectable, top material for the injectable technique. Here you can see the amount of the wear of this flowable. So this is injectable composite. You need to think of this as the paste composite in flowable consistency, because with all mechanical and aesthetical properties, it has similar properties like a regular paste composite. Here they try to compare flowable with paste composites, and amount of the wear is slightly lower. When we speak about a different bite registration material, you can use acrylic material, you can use silicone material, thermoplastic material. I use the first one nowadays, but in some situation you will use the other one. It's totally case dependent. Have in mind that you want to have only stable reconstruction of the position of upper and lower model, like it is in the mouth. The functional I'm speaking 2 hours about the functional analysis, but have in mind the most important stuff is the face bow register, of course, and to individualize your articulator, okay? Because with the face bow, we not only position the maxilla in proper horizontal orientation, but we also determine the position of each contact later on when we will be raising the bite. And the more precise in the planning you are, the more precise later on in the execution you will be. I'm always trying to capture the CR, centric relation position. Different materials you can use, different techniques. In this case, I'm showing you the interior, the programmer or jig, and with some other protrusional and lateral protrusional registers. I'm always trying to individualize articulator, because with the individualized articulator, with some certain lateral protrusive motions, you can plan the height of your cusp more precise. After the functional analysis, we also need to do the aesthetical analysis, because not only for the aesthetic, but because of the function, how much you're going to raise the bite. It depends also on the position of your incisor edge. Okay, I'm using SmileFi or SmileCloud or different DSD softwares. Recently, SmileFi, super easy to orientate yourself and to give some orientation to your technician, but also to your patient to visualize himself. You can overlap CBT scanners and so on. I'm doing the simplest thing, but you can also design in the software itself. It is good for the communication with the patients. Of course, nowadays we're trying to go more and more digital. All these parts you need to pay attention to when analyze your patient. Okay, and after the functional and aesthetical analysis is done, we go to some certain pre-treatments. Sometimes it's only calculus removal, but sometimes it's perio surgery. You need to raise the line of the gums if it's not symmetric, if it's lining on one side, and so on. This is not only for the composite veneers, for the ceramic veneers, ceramic crowns, full mouth rehab, for different indication. It's not only the white part, it's also the pink part. And this all we are covering in the functional program, different pre-treatments, which I'm sure some of you are doing on everyday basis. Regarding the wax up and the occlusal design, there are some specific things that you need to pay attention to. I like to stay with design only on the occlusal surface, raising the occlusal table, not covering too much of the vestibular or lingual, because I don't need material over there. It will be easier for me to clean it. Okay, here you have the cross section through the wax up, actually not wax up, but the design, which was later on printed, checked in the mock-up stage. Regarding the the contact points and the plan design. Have in mind, we're always trying to establish those big contacts, but here now we don't have enough time to elaborate in details about the planning of the bite. We always need to have stable occlusion bilaterally on both sides with slightly secluded anteriors, which purpose is to guide protrusional and lateral motions. After our technician made such wax up, here you have one wax up with the occlusal tables, with partial veneers, with raised bite in the new referential height, which is depending on the aesthetical analysis and the aesthetical parameters, everything captured in the centric relation. From this situation, they print such model, which later on we can check in the mock-up stage. The mock-up stage is crucial to check the contact points, to check the physiognomy of the patient, the lips, the rest position, speaking, phonics, and so on, all the functional things. Of course, in the functional program on the distal, we are more oriented to the function, but we need to pay attention to the aesthetics. One is following the other. There is no function without the aesthetics or aesthetic without the function. After we're happy, we go for the transparent silicone index production, which is cut a little bit different than for the anteriors. You can do full arch cases with one silicone index, or you can separate it in the smaller segments. This is, for example, how my transparent silicone precisely sit on the plaster model, and to give you the idea of the planned raised new vertical or the space that I will inject flowable into it. Okay. Then we go for the clinical procedure, which I already showed you at the half of the webinar. And here are some cases before after from the occlusal point of view, or this case on the left, we are elaborating in details from the aesthetical point of view, planning, surgery, showing surgical stuff, guides, and so on. On the left side, we did crown lengthening, upper 10 or 8 veneers, and lower 14 occlusal tabletops. So guys, I'm inviting you to join our upcoming functional program. It is containing 6 hours of educational content. You can find it on www.injectabletechnique.hr. It is available in English language as pre-recorded version, so you can get it basically today, or you can join our live session on 10th of June. There is the coupon that I will show you later on. Thank you very much for your attention. Hopefully this was you got some new information about the injectable technique. We can connect each other on Facebook, on Injectable Technique by David Gestakovsky, on Instagram, Injectable Technique Gestakovsky, LinkedIn. Here you have my Gmail, but if you will have any questions, feel free to ask or to share your cases, show your knowledge, show your experience, show your mistakes in this Facebook group, Injectable Techniques, Flow Injection Molding Technique. It's hopefully easy to find whichever synonym you are using. We're organizing different kinds of events. In the last 3.5 years, we have more than 150 events with more than 6 or more, I think even more participants in the online masterclass or functional program with 14 hours of educational content, with shorter webinars like this one, hands-on courses. By the way, on this on our educational platform, you can also find the schedule of upcoming hands-on courses in the following period. We are in Germany, in Switzerland, in Czech Republic. We have some plans also for going abroad, maybe to Canada, USA, Australia, Dubai, and so on. We are making demonstration private clinical courses. If you want to organize such 2 or 3 day event in your country, in your clinic, in your town, feel free to contact me anytime. I am open for any kind of collaboration. We are working with the GC getting great support regarding the material and models and stuff. So feel free to contact whenever you want. Once again, on our educational platform, www.injectabletechnique.hr, it's HR, not com, you can find free educational stuff such as my publications from Quintessence International Journal of Aesthetic Dentistry. You can find some educational tutorial videos, how to make transparent silicone index, full clinical procedure in video, and so on. Once again, I would like to invite you to our upcoming online masterclass, 8-hour in total educational video. It is combined of 2 webinars on 5th and 7th of June. If you plan to register, you can do it today or tomorrow with 10% discounted coupon, May 22nd, MAY22ND is the coupon code for the discount. The same is for our upcoming online functional program, which is 6-hour educational content on the 10th of June, also available in pre-recorded version. If you're interested in both, which I strongly recommend because one is covering one part, the other is covering the other part of full injectable technique story. We also have full package which with both of them. So hopefully we will see each other live once again. And now if you have any questions, feel free to ask. I will just go grab my phone and check the questions from the Facebook or Instagram. And in the meantime, let's see which questions do we have here. Ravi, are the foldable table talks strong enough for cuspal coverage? Yes, if you plan your occlusion properly. What does a veneer cost for the patient? I charge it double time than the freehand bonding. Totally depending regarding the price. It's totally depending on the country that you're living, on the economy, and so on. So it's useless to tell you my price because I'm from Croatia, guys from Serbia, Bosnia, Slovenia, Austria, Germany, and Switzerland. Everybody will have different pricing system, but I'm charging half price of ceramic, double price than freehand bonding. What is the mock-up material? No, the mock-up material for the mock-up material I'm using some provisional material like Temp Smart. Okay, the great material because it's dual curing. You can light cure it to speed up procedure and get a stronger provisional material. The Manuela, the thickness of the injected material should be thin in order to have such good color matching and the color characteristic. Exactly. The thinner it is, the background shade will come out and you will have better transition of the shade and better aesthetics. Ismail, how to remove bubbles when you discover them before light curing? You just inject more, you wait for bubble to come up, and the problem solved. As simple as that. Back in the days, I got a lot of bubbles in like 50% of the veneers. Nowadays, I got it in like every in 1 out of 50, one out of 100 veneers, maybe. The Muamer, šta je s biološkom širinom? Je li se mijenjala ovih dana? If you do the crown lengthening, you need to go for the removal of the bone. Of course, if you're going to remove a big amount of the soft tissue like I showed you, and always, Muammar asked about the biology, I'm always trying to stay supragingival with my veneers so we don't have problems with biological width and future biological problem. The question is, how is called the material for the mock-up? It is Temp Smart from the GC, Temp Smart. Okay, it doesn't contain plasticizer, so it has improved mechanical properties. Now I will check if we have any questions on the Facebook, if I will be able to see that. Okay. do you recommend working with rubber dam in front teeth? Well, you can, but rubber dam will cause you problem with the fitting, and it will be more challenging for you. And even without rubber dam in the anteriors, you can isolate it properly and not have problem with the isolation. Okay, so for the distal, I would advise rubber dam. For the anteriors, if you are super addicted to the rubber dam, go for the rubber dam, but have in mind you will need to cut differently transparent silicone and have less stability of it. What is your preferable injectable material? Genial Universal Injectable. Not Genial Universal Flow, it's also great material, but older generation, Genial Universal Injectable. It has FSC technology, which is patented by the GC, which gives perfect mechanical properties and have great gloss retention. And which, yes, it's also from the GC. What polishing material do you use? If you're asking for the polishing spirals, the one from the 3M is good, the one from the Ivoclar is good, the one from the EVE twist is also good, but the EVE is a little bit more aggressive, in my opinion. I like the one flexible. And for the paste, I use the Polisher paste from GC in combination with cotton buffer from Renfert. And cotton buffer on in the straight hand piece, because if you use the one which is on angled hand piece, it has small screw and you can rotate it only in one direction, and I like to rotate it in both directions, clockwise and counterclockwise, and this will give you better polishability from both mesial and distal part. Do you make your own silicone index? Yes, I make my own silicone index, or you can ask your technician to make it for you, but you need to give them certain instructions how to make it. So there is a question how to I need to know to translate. How to avoid material not to go over the gums. I am cutting my transparent silicone on the gum level. So everything that come out, I do flash polymerization and I remove it. And later on, with fine diamond polishing burr, I polish the margins. How to remove the excess from the interproximal surface with some metal matrix, which I showed you interdentally, and then with a scalpel blade number 12, and later on polish with fine stripes. How to avoid it? With the usage of space holder, which you can find in Quintessence International, or with the double models that I showed you in the slides. With double models, you make two transparent silicone, perfect interproximal surfaces. For the transparent silicone, I used a regular non-perforated metal tray to impress my transparent, my wax up, and I use ExaClear from GC for the production of transparent silicone index, because this is the clearest transparent silicone that you can find on the market. So guys, if there are no more questions, thank you very much for joining. If any questions arise, please remember and join our Facebook group. Ask any question over there. I will be more than happy to answer you. And if you want to learn really in depth about the injectable technique, we have more than 4 hours of educational content describing all this that I mentioned today, totally in detail. The online masterclass for the anteriors and functional program for distal teeth. Within next 24 hours, the coupon code May 22nd will be activated and you can get 10% discount on anything on our online platform. Thank you very much for joining, and see you maybe on some congress or some other hands-on course. Enjoy your evening, and thank you very much for joining us. Bye-bye.